All right, all right, all right. Hopefully, we're gonna get this right from the first try, one take. Let's do it. Um, Good evening. My name is Andrew Solomon, and for my capstone project for the Data Science and Biomedicine program, I am presenting my study on predicting irAE risk using machine learning. So this is just a quick table of contents of what we're going to discuss today. We're going to talk about the biology of irAEs, the data that I have, the previous work that's been done with this data, some of the clinical utility of machine learning and my inspiration behind the project, how we're going to avoid black boxes, the three main goals of the project, setup, evaluation, results, and the future. So, very quickly, um, this data set that I have is about irAEs. I guess we should take a step back and instead talk about what causes irAEs. So, about 2011, immune checkpoint inhibitors were first being developed as a new immunotherapy drug to treat breast cancer patients because, chemotherapy wasn't working out great or at least had some very big impacts on quality of life. Um, and researchers figured that if they targeted the immune system, and instead of allowing for, cancer cells to deactivate the immune system, could we competitively inhibit those ligands on the tumor surfaces and allow the immune system to proliferate and kill the tumor cells? So, as a result of this immune overactivation, we were able to see improved responses in breast cancer patients and remission, improved overall survival, etc. But because the immune system is overactivated, many patients will experience what's called an irAE, or an immune-mediated toxicity. So this is usually something that will affect any organ system, and it's more of a systemic dysregulation than an off-target toxicity. So this can range from something as simple as a simple dermatitis, like a rash, to something a little more severe, like a myocardial fibrosis, where the heart muscle tissue starts to become scarred. And like in the fourth bullet point says, grade 5 events can result in death. And so irAEs are relatively new therapies. The first clinical trial was in 2011, but they didn't make it to FDA approval and the like standard of care and regular oncological practice until 2020. And even then, a lot of them had their FDA approval revoked, and there's only currently one that's still being regularly used. It has great outcomes in terms of cancer, but they are also causing irAEs. And so irAEs are still a little incompletely understood because a lot of the data that we have is rooted in these clinical trials. So to address this gap in the literature, we decided to work on this study. This was me and my research team at UCLA. Um, Sorry. So, me and my research team at UCLA, this is a clinical research team, we worked with three other NCI designated centers, and we compiled data on patients that had been treated with ICIs for breast cancer specifically at their institutions. And we have those institutions on the right. So, that starts with us at UCLA, UCSF, City of Hope, and the University of Minnesota. And so, amongst the four institutions, we were able to aggregate data on about 1,100 patients that were treated with ICIs at any point between 2014 and 2024. And we decided to abstract data about their demographics, their known comorbidities, so stuff like hypertension, hyperlipidemia, their smoker status, etc., their baseline lab values. So when I say baseline labs, we're talking about their white blood cell count, hemoglobin, platelets, um, at least the instance right before ICI initiation. So what's their baseline lab value status? Information about their breast cancer stage. So are they early stage? Are they metastatic? And their subtype. So whether that's triple negative, if it's HER2 positive, etc. As well as their ICI treatment protocol, because ICIs could be given alone or they could be given in combination with chemotherapy. And we also procured data about their sustained irAEs and their irAE treatments. And so this led to a lot of great work being done. So we were able to actually write three different papers, um, and we studied a lot of different things. So we studied the incidence and risk factors of irAEs that occurred a while after ending ICI treatment. So is there a latent overactivation of the immune system that's leading to toxicity? We also investigated the incidence and risk factors of getting an irAE in early breast cancer patients, so anybody that's stage 1 to stage 3. And then we did the same thing for people with metastatic breast cancer, as well as their overall survival secondary to ICIUs. And this study was a little more pivotal because even with chemotherapy, early breast cancer patients have high odds at remission, but overall survival in the metastatic cohort was previously really low. And actually, we discovered that ICI use actually brought that up a little bit. So, why are we here? Why are we discussing this Why are we discussing these projects in this context? Um, I kind of sat down. I knew I had to do my capstone project. I realized I had this great data set, and I really thought to myself, I feel like I could bring a lot of the components that I learned in the master's degree to this data set, especially because all of those studies that we'd previously done were leaning on traditional regression. So we're estimating the average effects across a cohort, but we're not really getting any information about the individual themselves and using individual data to predict any sort of outcome. Um, irAEs from our studies, at least what we discovered here, there's a lot of different associations with irAEs, and for some reason they differ from cohort to cohort, right? So it's clear that irAEs are highly dimensional, and they're not exactly linear in the way that they interact between from patient to patient. And so there's no one single dominant factor. Like, for example, if you have a high baseline hemoglobin, you're always going to have predisposal to irAEs. Instead, we discovered that this is just that much more complicated for us to understand. And so all the past work that we've done retrospectively characterizes irAEs. And so I figured I could bring ML to the table. Why ML specifically? With ML, I would have loved to get some sort of patient level risk stratification. So can we guess whether a patient at baseline with the information that we have, can we actually guess whether or not they're going to get an I or AE? I also realized that machine learning could jointly model multiple risk factors. So we could take the effects that we discovered before through traditional regression and then feed it to an ML model and see how do these interact in a nonlinear fashion, right? Like it's not necessarily the case that just because you have a high eosinophil count, higher means higher risk for irAE. It maybe could eosinophil count be related to the timing of giving the immune checkpoint inhibitor, which is also dependent on maybe the age of the patient or their previous immune history or something. And so I wanted to work on this project that could produce a forward-looking, patient-specific risk assessment using the clinical features from our previous work. I talked to my clinical research mentor about getting access to the data or being at least being allowed to use this data for my capstone, and she was very open to it. She was very excited, but she was actually more concerned about the machine learning itself. And so she wasn't telling me this as a reason to not do the project, but as a concern that people might have down the line. Like, let's say I create this perfect predictor, it's able to get every single irAE, and she, as a hematologist oncologist, would be hesitant to use that in a clinical setting because to her, as somebody that's very, brilliant when it comes to clinical expertise and being a doctor and treating patients, she's not as familiar with the ML. And so she's not really sure what's going on under the hood. And so her concerns with machine learning were that these high performing models are opaque, they're difficult to interpret, we've heard the term black boxy a lot. And so a lack of transparency into the model's decision making would limit clinical trust. And so there's a big obstacle in terms of getting this integrated in real life. And then also, without any sort of insight as to what the model is doing under the hood, there's limited actionable insight for clinicians and future research to maybe, I don't know, maybe do some sort of bench work to realize what are the actual mechanisms. Like if we determine that eosinophil count is related to hemoglobin, is related to this other systemic index of inflammation or something like that, what is the mechanism behind it? So if we don't actually understand how these interplay and we can't interpret the reasons why a machine learning model is making the decision that it's making, there's limited actionable insight for future research. And so I really tried to prioritize some sort of interpretable ML that would avoid black box style decision making. And then I figured that SHAP values would probably be the best way to do this because they can actually quantify how much each clinical feature is contributing to a patient's risk prediction. And so that way, if a model performs well, it could be clinically contextualized, which makes clinicians more open to adopting it. And then it could also be validated against existing clinical knowledge and future research as well. So we have our three goals. We want to build a prediction model that uses multiple hypothesized clinical risk factors. We want to use SHAP to contextualize the drivers of irAE risk and validate my team's prior findings and see, does the model produce the same results as what we figured out before, or does it come up with something new that is worth investigating? So that takes us to model selection. And so when you think of this very tabular data, all of this lived in a REDCap file, so pretty much just Excel. And so we're talking about tabular data. These models come to mind for me. So I'm thinking logistic regression is what we used in the past. How can we improve on that? So first you think of decision trees, and then random forests and XGBoost. And so we actually in my paper, or at least my capstone manuscript, I kind of outline the reason why I chose XGBoost was because it performed the best on the baseline data before, optimization and yeah, optimization of the hyperparameters and stuff. But it also makes sense from an intuitive perspective why we'd want XGBoost as well, because it optimizes its performance by correcting prior errors. Whereas something like a decision tree is, very rigid, doesn't learn, it's prone to overfitting. And with such little clinical data, I think before we mentioned that we have only 1,100 patients. So we have 1,100 samples for a lot of engineered features that we're going to want to implement into this model. And so we want to avoid something that's going to be overfit. And it really came down to random forest versus XGBoost. And I thought XGBoost was probably a little better because um, it usually outperforms random forests, and that was the case in my paper. I kind of outlined the little study that I did, the mini study I did within the bigger study, to come up with, concrete numbers for why XGBoost was better. So now we have an experimentation pipeline. We're going to take in the raw EHR data. We're going to come up with some new features to implement in addition to the previously hypothesized features that we got from our previous clinical work. We're going to pre-process the data to make sure that we're not introducing any sort of, again, leakage, as well as making sure that we have a reproducible pipeline for, doing multiple experiments, whether we're tweaking the model architecture or we're tweaking the hyperparameters, et cetera. And so this is where we get a lot into feature engineering. And I think I tried maybe over, 70, 75 different feature engineered values. And this was the great part about having two experts in different fields on my team. I worked with my capstone advisor, Akos, or Dr. Rudas, as well as my clinical advisor, from my previous research. And so on one side, I had a lot of advice and mentorship on what are the correct techniques to go about doing a project like this, as well as, okay, if we come up with a feature engineered value, does this make sense in a clinical context? And so my clinical advisor was able to kind of unpack why certain values might track together. And from there, we get into model training, and then we're going to evaluate the best model that we can produce. And how do we evaluate? This is a quick overview because this was a slide that I'd mentioned to my clinical research mentor. But we're going to really heavily lean on the ROC AUC as well as the PR AUC because while one is really good for assessing the overall discriminative ability, it is insensitive to prevalence. So if something is very, very prevalent, that wasn't the case in this scenario. But if something is very prevalent, then PR AUC can provide context to the ROC AUC. And so these are the two main ways we're going to evaluate the model. So, after all of our feature engineering, our cleaning up, making sure that we're preventing leakage. So before, when I mentioned that we had, let's see, irAEs as well as the ways that irAEs were treated. So if you had a rash, did you get a steroid? Did you get a topical ointment, etc.? I took out a lot of that. It took a lot of critical thinking to be able to make sure that we're not introducing any sort of leakage into the model. To make sure that the best way of framing it or understanding the way that I kind of thought of it was what information would be present to a doctor when a patient first walks into a clinic. It's their baseline age, their demographics, their race, their ethnicity, whether or not a lot of these features over here in these tables. So their BMI, baseline labs, do they have any autoimmune conditions? Because we're talking about autoimmunity, any comorbidities, so like diabetes, hypertension, lung disease, etc., as well as the actual context that the ICI is being administered. So is it being given in combination with something else? Is it being given in combo with chemo, with hormonal therapy, with a targeted therapy? And so all of the features were limited to something that a clinician would know at baseline, and definitely not like the grade of the irAE that a patient got, definitely not the way that they were treated, because those would effectively being allowing the model to cheat. And so we kind of have some more descriptive statistics here. Um, and all of these at some point were fed into the model and were also used to actually build up those engineered features. And a lot of the engineered features are going to come over here from this side, messing around with the labs and their estimates to come up with these indices for inflammation, for immune frailty. And a lot of these are existing in the literature, and then some were just stuff that we kind of put together to see, does this interaction make sense? A little harder to engineer these features over here, like smoker status or their stage ICI, but it could also be useful in terms of the context in which the ICI was given. Like early and metastatic was very important for the actual. I'll get into it a little later, but it was actually very important down the line. Um, Here we go. So we kind of put together a lot of these in different mixed and matched ways. And we kept pruning them until I think our main criteria for pruning were if an engineered feature and an original feature had a Pearson correlation of over like zero point 0.8, then we pruned the new one. If they didn't provide any sort of predictive value when it came to SHAP analysis, took them out. And so we kind of decreased 75 different engineered features. I think this is about 20, give or take a couple. And these are the features that came up as most important in predicting whether or not risk. These were the most important feature engineered values that were important for evaluating risk. So later on, I'll show a shot plot that incorporates these as well as the baseline characteristics and the way they kind of interplay together. But to kind of briefly go over the engineered features, here we have the years between diagnosis and ICI to kind of give a snapshot of whether, was there a delay between diagnosis and treatment? Maybe there was time to maybe try chemotherapy before trying the ICI, or was it very quick and punchy? Did somebody realize, okay, I've been diagnosed with breast cancer, I want to start the ICI immediately? We have here a binary indicator of whether an early stage patient who initiated IC, yeah, whether an early stage patient initiated ICI within 6 months of their cancer diagnosis. And so this is what I'm talking about, or what I was talking about before, that some things that seemed a little unlikely for feature engineering actually ended up being pretty important. And so this identifies whether there's a timeline escalation for people with the greater prognosis on ICI. So we know from our previous work that early stage people responded better to ICI, or at least they have a better prognosis in general. Metastatic individuals have decreased prognosis or overall survival. So does starting this quicker put them at risk for immunotherapy, maybe because they're going to be on it for longer or what have you? We also have starting ICI quickly with their baseline, inflammation index. This is SII. That's over here. We'll discuss it a little more later. We've got the number of concurrent therapies. So if we have combination chemo that we talked about before, are they also being, sorry, are they on ICIs with combo chemo with maybe a targeted therapy as well, right? So how many concurrent therapies are they on? And then I guess just for the sake of time, I'll go a little more broader, but we also have some information about their composite immune features. So can we take the derived laboratory values that we got and put them together in aggregate, right? And here we put together, hemoglobin, their lymphocytes, albumin, and see is this predictive of irAE risk? And then for some of these are more baseline lab values for the aggregated um, indices. Can we aggregate the indices themselves that are actually so if we use, let's say, this these individual factors to come up with one of these, can we come up with a bunch of these indices to make one big inflammatory burden score, and is that predictive, right? So things of that nature. We have the baseline lab values. So we have estimated lymphocyte count, their systemic inflammatory index, their neutrophil to lymphocyte ratio, which is a very newly popular marker of inflammation. Can we come up with other things being related to lymphocytes? So this was neutrophil to lymphocytes, are platelets to lymphocytes predictive, are monocytes to lymphocytes predictive, and so on and so forth. And then here we have a couple things related to BMI. So is there a physiologic interaction between inflammation and metabolic reserve, etc. So this is just to describe, the things that were retained in terms of feature engineering. And now we get to the meat and potatoes of it all. Did our model work? Unfortunately, it didn't work as well as we wanted it to. We tried, or we were at least hoping for something between me and Akash. We kind of talked, and we were shooting for something that was like maybe 0.65, maybe zero point 0.7 to get into that range of like, all right, we've got like a really novel finding here. Um, it's better than a coin flip. It's better than a zero point 0.5 ROC AUC. But as you can see in the slides here, we have a mean AUC after cross validation of 604 on the training set. So a little weaker than we anticipated. The confidence interval does dip a little low, but also hits kind of high. And so, is there signal? Yes. Do we know exactly what causes it? No. And I'll kind of get into the reasons why this AUC might be a little low, why we were kind of limited in the sense of this project. But I guess the bottom line or the silver lining is that there's something there, right? We have point 0.6 we have zero point 0.6 on the training set, 0.62 on the test set. And so this actually hits a higher confidence interval. We almost get to that zero point 0.7. Of course, it's within the 95% confidence interval, but still, clearly there's something there, right? We don't know exactly what it is. Maybe there was a lot of limitation in terms of the sample size that we had. Originally, in the very beginning of the presentation, I said that we aggregated information about 1,100 patients, but after feature selection and preventing leakage and stuff like that, and limiting irAE risk, I should have mentioned before, with our target variable actually was, can we predict whether or not a patient experienced irAE within 1 year of initiation? So if somebody wasn't followed for a year, or if they, didn't have the days until their first irAE, then they were dropped from the data. And so we only had 800 points, data points to mess with. I think it was 844 exactly. Um, and once you account for a test split of maybe 70%, there's not a lot of information to learn from. We had a lot of features, we just didn't have a sample size. And so that kind of gets us to talking about P versus N and a lot of the stuff that we've discussed in the masters before. But um, I still thought it was worth mentioning, or at least, going along and seeing this project through, because there is some sort of signal. And maybe in the future, I'll talk about future directions later on, but in the future, there's definitely signal to kind of try to expand. Can we just get rid of that associated noise? And actually, PRAUC was a little better. Um, we had a baseline prevalence in the cohort of, I think, yeah, it was, yeah, 67, 68% um, of the individuals in the cohort of that 844 number. 67, 68% of those experienced an irAE within 1 year. So for us to come up with a average precision of 76% on the training data and then 79% on the test set, I was actually a little more pleased with that as compared to the ROC AUC, because it's not like we're just predicting that everybody's at risk, right? There's some level of discrimination here, some sort of precision. Again, it's not as high as it could be in an ideal sense, but still, there is some sort of a signal, and this confirms that this is real signal. This isn't just some sort of, we got lucky in terms of the seed of splitting our data, right? There's some sort of discrimination that's going on here. So yeah, we got almost 80% precision on the test set. I was pretty happy with that compared to a baseline of 67% at least. So, time to talk about, what were the most important features, right? This is the main thing that we're here for. And so inflammatory and immune indices clearly played the strongest role in risk determination. That's as can be seen by number one and number two. I'm not sure. It's my first time recording on Zoom. I'm not sure if my face is in the way. Um, okay, I moved myself. If that doesn't show up on the recording, if my little box doesn't show up on the recording, that's going to sound really stupid, but hey, yo, we move. So here we have the most important features. Like I said before, inflammatory and immune indices played the strongest role in risk determination. And when you realize that before, um, all of these at some point were included in the model, and we began pruning them based on whether or not they're giving any sort of, predictive feedback. But if they're not, like for example, if diabetes is not contributing at all, might as well just take it out, right? And so, um, when we look at this list here of the top 25 most important features, I think we had a total of 30, so this is pretty much all of them. Um, and all of them were predictive. It's just at some point they weren't really showing on this scale of negative zero point 0.4 to zero point 0.4, so that's why I decided on top 25 and just get rid of the final five. But to get to the point, um, immune indices really dominate here. You have immune reserve, the frailty, SII shows up a lot, MLR. These are all immune indices. White blood cell count, I'm not going to really count that because that's just a baseline lab value, but bone marrow reserve, you have a lot of these here indicating that underlying immune function is really important for predicting whether or not your immune system is going to overreact to this medication. It kind of makes sense, right? And so aggregation of the indices, actually, very interestingly, this is where it starts turning novel, right? Aggregation of the indices, so the reserve score, the frailty was more important than individual indices, right? SII and MLR, which was more important than individual lab values. So, your hemoglobin, your albumin, these drop off compared to the indices, which drop off compared to the aggregation of indices. Um, Interestingly, though, some indicators gave a mixed impression. So, of this class of feature engineered values where we're talking about immune function, right? We have SII, a high SI. What I'm about to say is kind of defeated by these little red dots, but over here, there's also a lot of red dots. Uh, I guess that kind of goes to show my point, right? So, we have SII red dots show up both on high SHAP and low SHAP contribution, whereas MLR, which is also immune function, is pretty well segregated, right? You have high MLR is indicative of high irAE risk, and low MLR is low irAE risk. Whereas something like where to go NLR, which is also immune, is on the opposite end, right? Like it's an exact flip-flop. And so I think the best takeaway from this, at least what we could come up with with our clinical team, is that while this class of indicators gave mixed impressions, there's a suggestion that immune dysregulation in general, rather than a global increase versus a global decrease, is predictive of irAE risk. So if your immune system, if your inflammatory response is mixed, then you might have a high propensity for irAE risk. Additionally, ICI context was pretty important, right? It stayed after pruning. And even though it gave a mixed role in directionality, a lot of that depended on the actual context, right? So, what I mean by that is here we have years between diagnosis and ICI. Um, we have if we have a very small amount of time between, it's probably going to err on the side of higher AE risk, right? But you have this little cluster here, and how do you kind of explore what's going on in that cluster, right? I decided to run, all right, do we have, where to go? Right here. Do we have quick ICI administration within the context of somebody being early stage breast cancer? And that really separates it really nicely, right? I assume that's probably what's going on in this cluster here. At least that's what makes the most sense to us in terms of clinical context, right? And this is the reason of why, having somebody on your team that's a clinician is so important. It might not make sense at face value to us that are really good at the coding side of it, but when I talked to my professor that's on the clinical side, she explained that, all right, maybe this is explained by the fact that somebody that is early stage has time to develop an IRA risk, whereas somebody that is metastatic might get the immune checkpoint inhibitor quickly, because that's kind of like their last resort, right? They've tried all these other things, then they get sorry, they don't get the ICI quickly. Sorry, I should rephrase that. They don't get the ICI as fast. Um, yeah, maybe they don't get the ICI as fast. They try other things before trying immunotherapy. They're on their last resort. And by the time they finally get to the immune checkpoint inhibitor, they're already very close to passing away anyways, that they don't have time to manifest with an irAE, right? Um, But ultimately, we could sit for a very long time and kind of unpack every single one of these values. And there's a lot of rich information here. I talk about some of it in my manuscript, in my paper, in my write-up. Um, but the quick Spark Notes version of it is that irAE risk is very clearly multifactorial, and it's better described by the interplay of characteristics and treatment timing and inflammatory indicators. It's a whole aggregation of these things rather than one single value, like those early papers were trying to elucidate, right? Like here, these are the final outcomes of these papers, right? Like any grade irAE, which is what we studied here, this is high grade. But they kind of focused and they say, okay, in early breast cancer patients, it's just the eosinophil count. And they know that the clinicians know that it's more than just eosinophil count, or else we'd be able to do a one-to-one mapping of people's eosinophil counts with their irAE risk. But they just didn't have a way of exploring what are the other things that have this combinatorial effect, right? Because we use ML, in this case, an XGBoost model, we're able to see that like a lot of the different ways that eosinophil count might manifest within these different features. So it's not just one single value. This provides clinicians that route out of this rut of just traditional logistic regression, right? Like, what is the next step for us to investigate? What are the other underlying factors that work together instead of that just show up on this log odds ratio, right? Course, with any study, there's limitations. Although irAEs are typically defined using a standard criterion, which is outlined here, documentation practices vary tremendously across sites, and not just the sites like UCSF, UCLA, Minnesota, City Hope, etc., but even just the doctors at UCLA and the different clinicians might describe the IRAs differently, might recognize them differently. I know this because on our earlier projects, I was the undergrad responsible for actually going into each chart manually, all 300 or 400 that we had from UCLA, and one by one, I have to go through note by note and find any sort of mention of IRAE. And because there's different doctors working on different patients, a lot of the doctors document IRAEs differently. And as a result, when we go to compile our data as different institutions, it might not be like a patient presenting at UCSF was going to get recognized with a toxicity the same way that somebody at UCLA was. Or if it, let's say both clinicians came to the conclusion of toxicity, the research teams might have different interpretations. And so once you get so far removed from the actual person diagnosing these irAEs, the target variable becomes very muddy. And I think that's a lot of where this noise comes from, right? That's why we're having a hard time discriminating. There's signal, but there's just super noisy signal. And so additionally, because our data was drawn from these academic centers, such an XGBoost model might not be generalizable to every single person, right? Because anybody that gets treated for breast cancer in a community clinic might have different access to these health systems, might have different interactions with the health system. So these results might not be fully generalizable. Another limitation of the study, I talked about it before, was the sample size. 844 samples is very modest compared to the number of features that we have. Here, after a lot of pruning, I brought it down to maybe 30 features, but even then, we have a very high events to value ratio, right? P to N is not as small as we'd want it to be, right? We want a lot of samples compared to the features that we have, and because this is real world data, we get really rich information, but it's very limited in terms of the number of different patients we can get with that rich data. And so that constrained our ability to include more feature engineered values, and a smaller training set required us to take precautions against overfitting, like early stopping in terms of the hyperparameter tuner that we used, or that I used. And so that limited the model's capacity to learn these complex features. And finally, I think this is probably the most important one to recognize, is that this feature matrix from this study was all originally developed and put together with three other studies in mind. This study that I came up with now was maybe a year and a half after we actually did this work. We did this work in 2023 and 2024. I go through 2025 with the masters, and I'm excited, and I'm learning all these different things with the different models that I can do. And it comes time for the capstone, and I thought it would be really cool to apply what I did to real world data, right? Like we can do that with the DDR, but I was like, okay, how generalizable is this to the actual data that people actually use in real world clinical studies, right? We're not just talking about the sandbox anymore, but this is the real world, right? And so, because the data was collected with other study objectives in mind, some clinically relevant variables that I would have loved to use in the context of a predictive framework just weren't included. And so, for example, here, ALC estimation shows up in almost every single one of these, right? Because ALC is lymphocyte estimation, which is used in something like the neutrophil to lymphocyte estimation, which is used in SII, right? Uh, um, so yeah, so if we're using if the very bottom of our pyramid is something that's estimated and I'm using a proxy value instead, the things that come up at the top of the food chain could definitely be much more optimized if I had been collecting the data for this project specifically. Another thing that I really wish that like another avenue I wish I was able to study was time series data, right? Minako talked about this a lot. Like for example, could we use in this study, I talk about, just the baseline characteristics and demographics, and lab values, etc. But what if I was able to give the model, the first 3 weeks of the patient being on ICI? So just taking a small, snippet, like early on when the patient's on ICI, they haven't had a lot of time to experience an I or AE yet. And let's say compared to, if you compare prior to ICI initiation and after ICI initiation, and there's this huge difference in lab values or these inflammatory indices or the aggregate scores. Could we predict, okay, you're probably going to get an IRAE down the line because your underlying biology is telling us that you were greatly affected, or at least you were physiologically affected by ICI initiation. So there was no time series data in the original studies because they were just trying to characterize irAEs in general in the real world because that didn't exist before. But if I had time series data, that would have been very useful for the models to really lean on. You get a moving average, you get, time versus like these lab values, time to yeah, time just would have been really nice to have. And so future directions. We talk about, the basics. We could always have more samples, more clinical factors, a new type of data in this longitudinally inspired follow-up data, right? With the labs I was just mentioning before. But there's also a lot of other things that we could do, right? From my last class in the masters, I took 209 and 220. And so in 209, we were actually doing a very similar project, and Dr. Meester can attest to that. And up until maybe week five, our projects are very similar. Week five and onwards, we start including genetic data in 209. And so I thought, hey, this would have been really cool, right? If I was able to get some genetic data secondary to a GWAS analysis for the irAE phenotype and then calculate this PRS score just like we did in 209, that helped our project in 209 tremendously in terms of the ROC AUC. In that class, I think our ROC was in the point sevens before genetic data when we were just talking about clinical factors. You introduce genetic data and it pops up to a point 0.9. Of course, we weren't as rigorous with the leakage, etc. But I would still be very surprised if we incorporated genetic data into this project that I'm talking about now, and it didn't significantly improve the model performance. But of course, again, like I mentioned before, this was data that was collected for different projects in mind, and I was thinking to myself, well, what if I use the UCLA data only, but then we're talking about, if I tried using the UCLA DDR and the biobank Atlas biobank, I only have 300, 400 patients that I have information on from UCLA, and it would be very difficult to ask all the other investigators to get GWAS data for a data set from UCSF, from Minnesota, from City of Hope. I don't think Minnesota or City of Hope have a biobank anyways. So would be great for a future project if you were starting from scratch. Wasn't feasible this time, unfortunately. Something that we also considered was what if we changed the target variable, right? What if we could get a predictor that could assess the risk of a high grade irAE specifically? So those that are carrying a very extreme burden and or are fatal to patients, right? So when we talk about grade 3, 4, and 5, 3 and 4 are high grade, 5 is a fatal irAE. And so I think patients would be much more interested in knowing, are they going to have a high grade irAE versus, while unfortunate, like, are we talking diarrhea versus, again, myocardial fibrosis versus death, right? So changing what the actual level of irAE is could be a very interesting question to ask. Um, and then also changing the test set. I kind of leaned on sklearn's handy little train test split. But if you hold out data from a participating institution or you use time validation, right? So let's say we collect the data from 2014 to 2023 for the training set, and we use 2024 as the validation or the test set. That could offer different ways of evaluating the model performance and is it generalizable to future years. So now we're in 2026. Could I predict whether a patient today in 2026, I don't know, right? Like down the line in 3, 4 months, are you going to get an irAE instead of having to, guess? We could just hold out an entire year and see can we predict that year's. Finally, the real world utility. So this study was the first to highlight the value. It was the first to, in general, try to understand irAE risk in breast cancer patients through a predictive framework. So in doing so, we were able to integrate all these different predictors that were categorically diverse to generate patient-specific risk estimates. Was it very accurate? Definitely room for improvement, but there's signal there, and that's why I was very passionate about getting this project out in time for the capstone. Um, and so, like it says in the second bullet point, I was very transparent in the evaluation of it. I had a coding expert and a clinical expert, and together we tried to come up with the most transparent value. We came the most transparent way of describing what was going on in the model, and that was SHAP. And so we all came together and we figured SHAP was the best to do this. And it really did provide a lot of insight as to the different ways that different features interact with each other. From a clinical perspective, something like this project, in terms of using baseline assessments to predict something happening in the future, like irAE risk, is a tangible next step towards this flavor of precision medicine. And that has implications for comprehensive treatment planning, right? Because somebody that is maybe a little towards the end of their life, maybe is metastatic, would want to know, right? Like, is the ICI going to allow me to live a couple more years? But what types of years are those going to be? Are they going to be in the hospital with a high grade 3 or 4 irAE where I have to be treated for Stevens-Johnson syndrome and like this your skin just sloughing off and like I don't want to get too into it for people that aren't as comfortable with the nitty-gritty hardcore clinical stuff, but like if somebody's going to prolong their life by a year or two, but they're going to spend 90% of it in the hospital because of the exact thing that's giving them more life, is it worth it at that point? And it doesn't mean that it's a definite yes or a definite no, but at least clinicians and patients can have that discussion. But for the present study, I think what we should take away is that this model is best reserved for hypothesis testing and exploration. But hopefully in the future, I hope to see whether I develop it or somebody else develops it. I hope this project inspires a clinically deployable irAE predictor in the future. That's been me. I'm definitely over my 10 minutes, but I had a lot to say. I just wanted to say I learned so much through the data science and biomedicine master's program. I would do it over and over again, like if I had the choice to, because this is exactly the type of thing that I want to do in the future. I'm going to mention it on the Google form, but I'm actually attending medical school this upcoming summer, and this is the exact kind of research that I want to give the medical field. Everybody kind of talks about um, AI in medicine and oh, AI is going to take over your job. And my first response is always not really, because somebody's going to have to be sued, right? You can't sue the AI, you're always going to sue a doctor. So, but really, like to be a little more serious, um, when we talk about AI being implemented in all these new fields, I really think that doctors have this responsibility of understanding what it is, right? Because it's coming whether we like it or not. But if it's going to happen, then we should have doctors in that conversation, because you don't want, you want a lot of context to what's going on here. And I was very lucky that I had a clinical advisor and a coding advisor or a technical advisor with Akosh. But in the future, 10, 20, 30 years down the line, if I could be two in one and, kind of contribute this sort of research to the field, I think that that would be an ideal combination of all the different passions that I have. And I couldn't have done it without the master's program. So I just wanted to say thank you for that. I'm over time. That's me. Thank you very much. Yeah.